So we'll go live in 5, 4, 3, 2, 1. Good evening all. On behalf of Academy of Lung Cancer, I welcome you all for the third CME of stenting in lung cancer. This multidisciplinary treatment approach discussion will help us to enhance our knowledge in clinical practice. With further delay, I will like to invite a chairperson, Dr. Shyam Sundar Tampi and Dr. Arun Gupta. Over to you, sir.
Good evening, everyone. Dr. Ulas has joined.
He will be joining a little later.
That's okay. So we all know that airway obstruction is a common problem in the lung cancer, and we are here to discuss the issues related to it, how, when, how to do it. So
not able to hear anything.
what are the problems we face? We have Dr. Rajiv Goyal today. He is going to discuss about the problem statement, what is the problem, and how to approach a central airway obstruction. Dr. Rajiv Goyal is Senior Consultant Respiratory Medicine Department at Rajiv Gandhi Cancer Institute, Delhi. Dr. Rajiv Goyal, please.
Thank you, Arun, and thanks to the organizers for giving us this opportunity. I think it's a wonderful thing that this Academy of Lung Cancer is doing, because it has brought, for the first time, in my memory, the pulmonologists, the medical oncologists, and the interventional radiologists together in trying to approach a common problem, which each of us address a little differently, and which when the whole thing is discussed on a common platform, makes a lot of sense and more sense to each of us. So today's theme is basically central airway obstruction and primarily stenting, airway stenting. So I, in my initial talk, will talk about what central airway obstruction is about, and how it affects patients, and what is our the pulmonologist's approach to central airway obstruction, and what are the different ways of addressing it. So can I share my screen, please?
Yes, sir, you can.
Please. Okay. Has it become visible?
So it is visible, but nothing is there on the screen.
Yeah, so let me try again.
Yes, sir.
All right. Okay, I think we are you are seeing something now, isn't it?
Yes. So you need to full screen your screen.
Yeah,
Fine.
Full screen. So is it visible now?
Yeah,
yes,
now
sir,
it is visible.
Okay, wonderful. So basically, I'll be talking about central airway obstruction. What is the problem and what is our approach to it? So basically, when we, we find that it is a pretty common issue for pulmonologists, especially who are, dealing with patients of lung cancer, and about, where the data is more available. We know that there are large number of patients in the US, for example, 80,000 patients per year present with central airway obstruction. And almost a fifth of these experience significant morbidity due to cough, dyspnea, and obstructive pneumonias. It is a fact that about 35 to 40% of patients of lung cancer actually die due to the complications of locoregional disease, which means that when they get obstructed in the larger airways, they can then develop either life-threatening respiratory failure, or they can get obstructive pneumonias, collapse of the lung, and so forth. So basically, the pulmonologist is often called to see such patients and try to address these problems. And the next 15 or 20 minutes, I'll try to take you through how we go about it. So just to kind of brief you quickly about what are the causes of tracheobronchial stenosis, you find that amongst the benign diseases, endotracheal intubation and tracheostomy, these are two areas which often result in subsequent benign tracheal stenosis, and this is by no means uncommon. And many of our patients with lung cancer also, if they've been on the ventilator or they have been treated earlier, for respiratory failure on ventilators, or have had a tracheostomy for some reason, they can, later on present with patient with tracheal stenosis. Similarly, tuberculosis in our country is very common. So that is another, confounder and can cause, benign tracheal stenosis. Amongst the malignant causes, if you take it, you find that most common malignant causes are due to direct extension of extrinsic tumors into the airway lumen. So this could be because of bronchogenic carcinoma. It could be because of esophageal and thyroid carcinoma, which are, contiguous structures, and these can cause mixed type of, central airway obstruction. Primary tumors or intrinsic central airway tumors are relatively uncommon. And of these, if you look at them, you find that amongst older patients, large majority of them are these squamous cell type. And in the younger age group, you find that adenoid cystic carcinomas, carcinoids, these are present in younger patients, and we see a fair number of these patients, in our practice. And less frequently, you will have metastasis from the breast, kidneys, colon, thyroid, and esophagus, which may give rise to central airway obstruction. Now, once you have a patient with central airway obstruction, how do you approach it? You find that the choice of intervention is generally dictated by the patient's stability. How stable is my patient? If the patient is obviously very, very unstable, then the first job is to, secure the airway and make sure that the patient is getting adequately ventilated. And after that, only address, problems. So there can be patients who come in dire distress and first have to be, dealt with accordingly before you actually deal with the central airway obstruction. And then it depends on the nature of the underlying problem. So, for example, where is the obstruction? Is it in the trachea? How critical is the obstruction? And whether it is causing, distal collapse or pneumonia. So that will decide as to what you want to do. The overall prognosis of the patient is very important. For example, if a patient is, terminal, there is no point in trying to do something very heroic and remove his central airway obstruction. On the other hand, if the patient has got a good quality of life, he's been having a reasonably good performance status, and especially if the patient has not had any oncological treatment as yet, then if the local expertise is available and the technology is available, then you should definitely try to approach the central airway obstruction. As I said just now, multidisciplinary team approach is essential. So you need your radiologist, your anesthesiologist, your medical oncologist, the thoracic surgeons, and all of us to sit together to decide what is the best for a particular patient. Now, if you look at the patient with central airway obstruction, most of them will present with cough. They may present with exertional dyspnea. So when the obstruction increases more than 50% of the lumen, for example, when the trachea is more than 50% obstructed, the patient will start to have dyspnea. And when it becomes, about 5 millimeters diameter, which means about a third of the trachea is only open, then they start having stridor. So how can you, further investigate these? So you can do a spirometry. If the patient is able to perform, then you'll find that there'll be a blunting of the flow volume loops, and the values of the FEV1, FVC may be reduced. And then you may go for, further imaging and finally a bronchoscopy. So let's just talk about each of these. So your spirometric loop, if it's a fixed obstruction, say by a thyroid carcinoma, extrathoracic, then it can look, the inspiratory loop and the expiratory loop will be flattened. While if it's a variable extrathoracic obstruction, then you might find that only the inspiratory loop is flattened while the expiratory loop, because of positive pressure, is patent. While if it's a, intrathoracic airway obstruction, then you will find that during inspiration, the loop is all right, but during expiration, when there's positive, intrathoracic pressure, then the loop gets flattened. So, any of these loops can be present depending on the type of obstruction, and this can give you an idea. Spirometry also helps because once you have removed the central airway obstruction, you may repeat the spirometry to see how much functional, improvement the patient has, got. Then, of course, a CT is invaluable. So CT can show you, for example, like in this case, it can show you a very tight stenosis in the trachea. You can see the portion of the trachea above and below the stenosis is fairly patent. So that can give you an idea. A coronal, reconstruction can tell you where exactly the, stricture is and how long or short the stricture is. That can help you to decide what type of treatment you want to give him. A bronchoscopy has to be done. and that gives you an idea, exact idea of what kind of lesion you are dealing with. You might have to take a biopsy if it's not already been taken earlier, and you may have to then, in the same sitting or in a subsequent sitting, decide as to what treatment you want to go ahead with. So that was a malignant tumor, or you may have a benign tumor like this, a web-like stenosis or a mixed stenosis like in the slide below. Now, of the central airway obstruction, you find that the intrinsic obstruction, like in the first part of this slide, you find that if it's an intrinsic obstruction, then usually debulking maneuvers are employed. You want to just debulk the tumor, and that will give you patency. On the other hand, on the right side, if you have, on the middle, you have only an extrinsic obstruction, then you may want to do an airway stenting. However, many times you have mixed type of obstruction where there is both an intrinsic, intraluminar component, the mucosa and the wall of the trachea has been sort of now eroded by a large tumor outside. Then you may want to couple a debulking procedure along with an airway stenting to keep the airway patency. So depending on the type of obstruction, you may decide what you want to do. Now, what are the indications for bronchoscopic management? Now, broadly, we divide them into three. There can be a curative, intent where if there's a benign stenosis, or say there is a typical carcinoid, you may want to, do away with whatever stricture there is or tumor there is by bronchoscopic treatment alone, and surgery is not required. You may want to facilitate treatment. That means the patient has not had oncological treatment so far, but he comes to you with obstruction upfront. So you deal with the obstruction, and then you can send the patient in a better shape for his subsequent cancer treatment. And then, of course, you have palliative treatment where the patient has already received oncological treatment, but now is suffering from either a recurrence of the disease or progression of the disease, and requires relief of the airway obstruction to give him symptomatic relief. So any of these type of indications can be there. What are the various techniques? So you have either the rapid technique, which can give you rapid deobstruction, or you have the slow techniques like brachytherapy or photodynamic therapy. I'll be talking mainly of the rapid techniques today. So balloon bronchoplasty, mechanical coring, electrocautery or laser, stenting is going to be talked in detail today, and cryo. So I'll just briefly touch upon these. And if you combine these modalities, that is what is called as multimodality treatment. Now, balloon bronchoplasty, quickly you can see that these are balloons which are inflated to different sizes. These balloons go easily through the working channel of the bronchoscope. They are called controlled radial expansion balloons. They can dilate from 4 millimeters to about 16 to 18 millimeters, and they are inflated with saline and a prescribed pressure. And once you kind of inflate these balloons, you get good dilatation. So the patient must be oxygenated before and after the procedure, because he may be apneic if you're doing the balloon dilatation in the trachea. And it is a procedure with low complication. It is easy to learn, and usually there is no problem. Airway tears or ruptures are very rare. But yes, if you do a balloon dilatation, you should be ready that there is a possibility of recurrence of the of the stricture, and multiple procedures may be required. So this is an example of a patient with a balloon bronchoplasty. He had a very tight stenosis. As you can see, a cautery was done, and the stricture has been opened to some extent, and then a balloon has been placed, and the stricture has been dilated, and subsequently a silicone stent has been placed to keep the airway patency and prevent recurrence. So this is an example of balloon bronchoplasty. Now next is mechanical coring. Now this is normally done with the help of the rigid bronchoscope. The edge of the rigid bronchoscope, as you will see here in this particular video, is used to actually core out the tumor. For this, it is very important that distal patency must be there. Usually the tumor should not be too large, not more than 4 centimeters, as they say. And you can see here with the corkscrew movement, the tumor is being cored out from its moorings in the airway wall, and then the cut out tumor is being sucked out. This gives immediate results, but if it is not done skillfully, if it is done with too much of force, it can result in perforation and bleeding. So you have to be careful in trying to do whatever you're doing, and it requires skilled hands. So that is mechanical coring. You can see here another example of a patient with a large tumor completely impacting the right main bronchus, and after coring, he's got a good result where the patient has got complete airway patency. So this kind of result is possible with coring, but as I said, you need to be skillful and you should be adept at rigid bronchoscopy. Then electrocautery. Now this is something which we use very common. We know that electric current is used in cautery to destroy tissue and coagulate bleeding sites. A high frequency alternating current is used, and the current passes through living tissue with a probe which is in contact. Unlike laser, cautery uses contact, and depending on the degree of tissue destruction which is required, you can either coagulate or cut. Higher temperatures will cut, while lower temperatures up to 70 degrees will coagulate. So normally this is again a method for rapid debulking. You can do it either through the rigid or the fiber optic bronchoscope, and can be used singly or as a part of multimodality treatment. So you may start off by cauterizing the tumor, and then later on do mechanical coring and to complete the job, and then finish up with stenting. So this is the these are cheap accessories of cautery. This is the simple cautery machine which is available in most operation theaters. And you can see here a curative resection of a typical carcinoid. You can see the tumor in the right, intermediate bronchus, causing collapse of the lower lobe. And you can see here that, this tumor is impacting the right intermediate bronchus. As one goes inside, we are doing a little bit of cautery to see whether it is a, bleeding type. Then a snare is being passed around the, you can see the snare being passed there. The snare has been passed around the tumor, and by coagulating, the tumor is cut, and you can see the tumor being sort of removed. So this is the kind of thing that you can do with cautery. Now this is another modality, which is cryotherapy, which has come about recently. The cryotherapy involves using a probe which is hollow from the inside, where pressurized gas, usually it will be either nitric oxide or nitrous oxide or carbon dioxide, and once this gas comes out of the tip of the probe under pressure and then suddenly meets a low pressure zone, it quickly sort of the temperature is lowered to about minus 89 degrees centigrade, and that causes a ball of ice to form around the probe. Now this probe, when it's touched to tissue, you can see this probe goes very easily through the working channel of a bronchoscope. And you can see here that once the the tip of the probe touches the tumor, it causes a ball of ice to form. So when the probe is pulled out, it takes a part of the probe away. So I'll show you in a quick video again. You can see here, this is a tumor in the right main bronchus. The probe is coming slowly close to it. You can see the probe being touched to the tissue. So about 5 to 7 seconds of cooling. So once that is cooled, when you pluck the tissue, there. So you can get large pieces. So usually you do it through an artificial airway, so that you can repeat the procedure repeatedly. And you can see that, just as much time as this video takes, the right main bronchus, being completely opened up by this procedure. The tumor in this case was in the right upper lobe, and you can see here the right intermediate bronchus completely open, while the tumor has been reduced to its base in the right upper lobe. So cryo is a wonderful thing and can be used for rapid debulking. Now tracheobronchial stenting, I'll not go into the detail because we are having two experts here who's going to talk about them. This is ideal for central airway obstruction due to extrinsic compression or for fistula closure. You may use either a silicone or a self-expanding metallic stent, and these people will be talking about that. You can use it. The rigid is used mainly for the silicone stent, and the fiber optic can be used for putting the metallic stent. The metallic stent, of course, can be put with the rigid as well. Now you can have either straight stents or Y stents, and again we'll be hearing more from the experts. So multimodality therapy is use of more than one type of intervention for solving problems of patient with central airway obstruction, often required for mixed type of obstruction. So usual combos will be dilatation with the balloon, rigid bronchoscopy with stenting, or you may have a cautery laser followed by cryo, and then coring for debulking, followed by stenting or brachytherapy. So if you acquire, IP specialists believe that the more skills they acquire in, doing these various techniques, and more technology that they, procure in their units, the more they are able to, deliver in terms of safe and efficient, removal of central airway obstruction. So this is a patient with a large tumor in the, trachea, where initially we are doing some cautery. So started with cautery, and then followed up with a little bit of coring. You can see here, once the tumor was cored, you can see that the the patency of the trachea has been achieved, but it is looking quite diseased, the trachea. So it is important that we keep the patency by doing some stenting. You can see the distal carina is actually clear, and self-expanding stent is put in. So for that, a guide wire is first put in, and then the guide wire is followed by you can see here a deploying catheter with the stent is being passed into the trachea. The fiber optic bronchoscope has been kept alongside to see where the stent will open, and the stent you can see opening beautifully like a flower. And this is an aero stent which has been deployed in this particular case to take care of the airway obstruction. So airway stenting is actually a wonderful technique which most of us have learned while on the job, but it has delivered a lot of palliation and help to a lot of our patients with central airway obstruction. So to sum it up, I would say that if you have a patient with central airway obstruction, if it is an emergent, yani ke the patient is coming with an emergency problem, then yes, you need to look at whether you are dealing with an extrinsic lesion or an endobronchial lesion. If it's an extrinsic lesion, you do a dilatation and stenting. If it's an endobronchial lesion, you may want to do coring, electrocautery, or argon plasma coagulation. On the other hand, if it's not the patient is not in dire distress, then you may consider whether the patient is a possible candidate for surgery. In case he is, then he goes for the surgery. But if he's not, then again the same thing follows. Are we dealing with endobronchial, which means then you can do the either the rapid debulking, or you can also opt for things like external beam radiation or brachytherapy. While on the other hand, if it's an extrinsic lesion, you may do a dilatation, you may consider stenting along with external beam radiation. So that brings me to the end of my talk. I hope I have been able to bring together all the components of how central airway obstruction is normally dealt with, our approach to these patients. But mind you, this is a team game. You have to have skilled people. You have to have a good anesthetist who believes in you because you're sharing the airway with her. You need a good radiologist who will be at hand to guide you about what kind of lesion you're dealing with. And of course, you need to acquire skills along the way to do this job. And last but not the least, you need a medical oncologist without whom the patient would not be on the table. And he's the one who actually continues the battle when we are done, for better or for worse. So with that, I come to the end of my talk. And I think what we could do is to take the questions at the end of it or during the the moderation which Ullas will do, and then we can take it further. Thank you so much. Thank you very much.
Thank you, Dr. Rajiv.
Thank you, Dr. Rajiv.
Before any discussion, I would like to introduce my co-chairperson for this meeting today, Dr. Shyam Sundar Thampi. He is a senior consultant pulmonologist at Bombay Hospital, Mumbai.
Thank you, sir. Thank you very much. I think that was a wonderful talk with so many demonstrations and fantastic videos by Dr. Rajiv Goyal. I think we can move on to the next topic, which is on airway stent types, indications, advantages and disadvantages, by none other than very, very popular Dr. Patabi Raman. He does not need any introduction. However, he is the Director of Interventional Pulmonology at the Royal Cancer Hospital, Coimbatore. Dr. Patabi.
Dr. Shyam Sundar, may I just add one or two more lines in terms of introducing our friend Dr. Patabi. Let me tell you all that Dr. Patabi is one of the pioneers in interventional pulmonology in the country. He was the one who brought EBUS to India. He was the first one to bring EBUS to India. He is also the one who is the first one to bring bronchial thermoplasty to India. And he has been, he may look very young, but he is, very, very experienced and has done a huge amount of work in interventional pulmonology. So I think it will be a privilege for all of us to hear him.
Thanks a lot, Rajiv. Thanks a lot, Dr. Thampi, and thanks for the organizers for giving this opportunity. Now, can I share the screen now?
Yes, sir, you can.
Yeah. This is the one. Can you see the? Can you see the?
Yes, I can see.
Yeah, sure. So this is going to be next 10 to 15 minutes is about the nuts and bolts of tracheobronchial stenting. I mean, we've seen Dr. Rajiv clearly explaining how an approach would be for a central airway obstruction. You can't see my screen? So what are you seeing then?
Yeah, Zoom. It's a Zoom screen.
All right. I'll start sharing this. I've opened that. Hang on. Yeah. Can you see the screen now?
Not yet, not yet.
How can you now? Because I'm seeing it.
No.
Well, this is a Mac. Is it any different here? I'm seeing the screen, but I'm not sure why you're not seeing it.
You can see your cursor.
Seeing a whiteboard now, is that?
Yeah, it's just a whiteboard.
What are you seeing now?
But
Where in the whiteboard is it? I'll stop share. I'll start again. I'll start whiteboard. This is a basic advanced in files. There's a Google Chrome. It's a. Hang on. I'll stop share now. I'll mail it to whom? Can you just tell me what it is? It is a 281 MB. That wouldn't go, no?
That will go by Drive, Google Drive. So when you click the share screen, doesn't shows what are the options you have to share. In that you have to choose your PPT.
I don't know. This is the first time this is happening. Can you see the screen now?
no, not able to see.
Wait a minute. Now I'll have to open this again. The PowerPoint. Now what do I do? Can you hear me?
Yeah.
I'll now share screen. When I share screen, it says basic and advanced. I'll go advanced now.
Okay.
And slides as virtual background. Is that the one?
Slides. No.
And then it says computer audio, and then there is one video, and then content from second camera. These are the things that I get. And I have files.
Files.
Microsoft SharePoint is there.
Yes.
I'll click that. But it's going somewhere. No, it again goes to Zoom. And I think it's going to Zoom and all that password and all that stuff is asked. Okay. Presentation is minimized. Yes. No, I just have two options. One is whiteboard. Another one is Google Chrome. Google account is what I see. I'm seeing my presentation is just minimized. No, I don't get it on that tab. Let me open that and see if my presentation is there. Yeah, now can you see that? No. How do I then? Oh shit! I've never had this problem.
So what I can suggest, if everyone
should I go and join back again? Would that help?
We go ahead with the next presentation. In the meantime, we fix it.
Okay.
Praveen.
Yeah.
Yes, sir. Jonah, can we take next topic for the time?
Patta,
Ah,
is it possible for you to send these slides on Google Drive to these people?
I can send that now.
And then what we can do is we can start Ravi's presentation because that is on record.
Ah.
And then you can come back in 15 minutes and then, do your presentation.
All right, I'll do that. I'll do that now. I'm sorry, terribly sorry about this.
No.
It's a technology glitch.
Yes.
So let's get on to the next topic, which is on deployment of airway stents, techniques and complications. It's a case-based discussion by none other than Dr. Ravindra Mehta, who is a senior consultant pulmonologist and specialist in critical care medicine at Apollo Hospital, Bangalore. So, Ravi, if you're ready, we can start.
Hi everybody, my name is Dr. Ravindra Mehta and the topic given to me is airway stenting in malignant central airway obstruction. I've taken it from the picture of lung cancer to the larger picture of malignant CAO, and the focus is on techniques and complications with a case-based approach. I first would like to thank Rajiv Goel for calling me to take this talk and hope that it adds to the bigger picture of an interesting meeting which has been organized on this extremely important topic. So today's focus is going to be, by and large, we're going to talk of didactics literature, but we'll base it on cases and videos and leading to data. We'll start with some real-world illustrative cases, talk of the core issues, and go over what all else is there in data, and then summarize the whole talk in the 15 minutes we have. The case is an interesting prototype which epitomizes these principles. A 59-year-old with a renal cell CA after nephrectomy gets hemoptysis, has a CT scan showing a node going into the left main bronchus and narrowing it. Bronchoscopy is also showing a narrowed left main bronchus, which will show you with a big problem over there. What do we do? Dual problem of both airway obstruction and recanalization. Well, we started over here. You can see the check bronchoscopy going in under suitable sedation. Left main bronchus blocked. Clearly, the tumor is a cause of this bleed over here. And so in this situation, something needs to be done. A therapeutic modality approach is planned. We go in there with a rigid bronchoscope. We have to both recanalize the airway as well as fix the hemoptysis. Over here, you'll see the operator using suitable tools, the rigid bronchoscope barrel. A balloon goes in there so as to figure out the distal airway. Keep in mind, no distal airway, no recanalization. A stent is put over here. Just to show you once more, this is a metal stent which has been deployed over there, and this stent serves a dual purpose of both recanalizing as well as helping us to control the hemoptysis. So for those of you who have missed it, here is a distal airway wide open, very important for a bronchoscopist. Here is the stent, and that is the procedure. The patient did well after that, and at least his immediate problem as well as his issue of trying to get the airway back was solved. A second case to show you similar principles, a bronchial asthma gentleman, a case of bronchial asthma with a past history of malignancy, comes with shortness of breath. Everybody calls it an asthma exacerbation, but no, the CT shows there is a mass going into the trachea, which is evident on these lung windows. It's a problem because initially treatment has gone on the side of asthma and he's not responding to asthma therapy. A quick bronchoscopy gets done. You can see there is major trouble out here. This is the trachea. So again, to show you all over again, this is the vocal cord. The operator walking down cautiously. There is extrinsic compression, vascular compression. The operator tries to slide past over there to try and see the distal airways. The distal airways are full of pus over here because of post-obstructive infection. So we have a major issue out here, but the distal airways are open, and we will come back to this point later when we review literature. So clearly something therapeutic needs to be done to make this gentleman come out of his distress, and a Y stent is put over there. You can see this is the limb, the left main limb of the Y going over here, which recanalizes that area. This is the right main limb of the Y and the open right main bronchus, and here up is the tracheal limb of the Y, which you will see very clearly appreciated, the tracheal limb, which is totally giving us successful, comprehensive tracheobronchial airway opening. So this gentleman had immediate relief of his symptoms, did very well, and basically went in for multimodality therapy. A third case to show you some of these principles, CA thyroid with tracheal involvement. Initially had a rigid bronchoscopy similar to what we showed you. A stent was placed, but the patient just could not tolerate the stent. So the stent was removed. That was a metal stent. SEMS stands for self-expanding metal stent. Again gets hemoptysis, so you have no option to airway recanalization. Here goes in the operator over here. We went in with a rigid scope, bad airway compression. You don't need to be a pulmonologist for all this. And this has happened after metal stent removal. Here you can see cauterization happening with appropriate instruments over there, and then balloon dilatation to restore the airway. And then you can see this is a silicone stent. We showed you metal stents before, silicone stent because he could not tolerate the metal stent. A silicone stent is adjusted appropriately. The operator is opening it nicely over there. It does the job of recanalization. We are putting a tug over there to make sure it's a good fit, and that gives this person their airway back. What do these three cases show us? Where these are all stenting done for central airway obstruction in malignant disease. So now the main topic, technical details. What did we show you? We showed you that the stents can be either silicone or metal. So that is one decision point. In malignant disease, you can do either one of them, but the leaning is towards metal for multiple issues, predominantly cost and easier technique, and the technique part will get into why. In benign disease, on a small note, that's only reference, metal should be put only as a last option and only a completely covered metal stent and no less. Otherwise, silicone is put. The principles in any obstruction is you got to go beyond the obstruction. So this is the distance, at least 0.5 to 1 centimeter above and beyond as much as possible. And ideally, more than 2 centimeters below the vocal cord so as to prevent irritation, which may not always possible. Inner stenotic lesion we dilate, And then there are some things called hourglass stents, which you don't have a country. You saw us trying to make sure the stent is a tight fit to prevent migration. Other technical issues, why do we prefer a metal stent? Because it can be done by flexible scopy, which is what most pulmonologists are comfortable with. Silicone requires a rigid scope, so that's why in malignant disease, by and large, most people prefer metal in addition to the cheaper cost. Other areas, technically, where there's distorted anatomy, the metal will find its way, so metal is preferred, especially with compression, which is a feature of malignancy. In a wide stent, rigid is preferable, but very technically adroit and skilled operators like Dr. Goel will prefer a flexible. Otherwise, a lot of us will use a rigid scope. If you have to customize the right upper lobe, now we're getting into geography. You have to make a small hole that cannot be done with a metal because it's a single conduit, so silicone is better. In a fistula of a malignant nature, we prefer metal because it approximates better. Ultimately, with all these factors, local expertise, cost, stability, and anatomy will be the decision making for which stent. But let us see what data is there when we go through these theoretical principles. In this interesting paper which came out a while ago, they looked at what are the decision making points over here. They developed a prediction model. Favorable results are there with tracheal location, endobronchial disease, and extrinsic compression. And there's a reduced likelihood of success if there's a left main obstruction or mucosal infiltration. All these rules get broken in some of the cases we showed you, but data showed us these particular aspects. So by and large, this is a case in a novice and a beginning situation you would like to select. Another paper which talked of predictors of survival in malignant obstruction. Patients who benefit the most will be with purely endoluminal lesions in whom a technical success was achieved, like our cases. Those on whom cancer-specific treatment was initiated, that means you had stuff beyond the stent. You could give them chemotherapy, radiotherapy, immunotherapy, and so on. And distal airway patency on thoracic CT predicts the technical success. We extended that to bronchoscopic opening. We paused and showed you that where the distal airway opens is where you have success of a true nature, which is patient beneficial. Understand that is why between radiology, oncology, and technical pulmonology, it's multimodality all the way. And this message, I'm sure, comes to the length and breadth of this meeting. This is a recent paper in 2020 which puts forward all the principles I talked about, a good paper to read. And again, they talk of the silicone and metal paradigm, which we have discussed at length. Complications, the second part. Complications are part of our lives. It could be, and this is a myriad discussion, but I'll make it brief in the time we have. Either it's insertion-related complications related to anesthesia, rigid bronch, flexible bronch, or technical issues. You haven't sized it correctly, obstructing segments, and so on and so forth. Later, it is not a panacea. Since the airway is a mobile area, you breathe all the time, and there is external environmental influences, granulation, obstruction with secretions, and a tip for that is don't overstent. It's not like cardiology that they put that 4-5 stents are good. If you try to put Y stents, Y plus main stem stents, the airway will not allow secretion clearance, especially understanding these patients are weak, they have cancer, and they have infections. So do that, and nebulization helps in trying to clear the airways. Migration is a problem. Stents are like mechanical devices. They're subject to technical issues. And if you have to take these out occasionally, it can be a problem to take out metal stents because they tend to marry the trachea with a lot of sticking over there. Complications, more papers out there in a registry which came out recently in chest. By and large, endoluminal obstruction, as we said earlier, and stent placement favored technical success, like our cases. And they also did not like the left main lesions, albeit we showed you a good one in our lecture. Additional predictors of failure are patients who are sick, renal failure, primary lung cancer, very interestingly, and T fistula. Nevertheless, this is one observational series. There are anecdotal and other observations which may or may not totally agree with this. Primary result complication rate 4%, though in our mind, and Dr. Goel may agree, and other people may also concur, it's much more than that. What is our other papers out there? Another person, single center experience, said that median survival was 15 weeks, 2% risk of complications, as we talked about, and most of them don't like renal cell carcinoma, though we've shown you one case of RCC, which was dealt with in the first case we described. Indian imprint, a lot of us got in together, including Dr. Goel over here, including our group and the AIMS and PGI people, and Coimbatore, where we showed that you could put in wide stents successfully in India, and one of the largest series of wide stents in literature with a decent outcome, most of them being CA esophagus as the indication. And a similar imprint again with both Dr. Goel's group and a lot of us, including PGIMs in Hyderabad and Coimbatore, who have also showed the same thing can be done in silicone wide stents. What about migration? We had a particular paper where we showed that you can actually do a percutaneous stitch to prevent migration and mitigate the complications, especially in these oncology patients where we don't want these patients to go through repeat procedures. It's a simple stitch with a subcutaneous closure, so it does not leave us a major outside button or a disfigurement. So it has been an innovation which we have put out there in worldwide literature. New things out there, well, customization. Why not customize these stents? And I don't have time for details, but 3D printing is coming in stentology so as to make things better over there. And you can see these pretty pictures which are trying to make sure these weird shaped lesions with compression can be somehow compensated by preparing 3D printed good stents. Another concept borrowed from other areas like cardiology and maybe GI, why not have a stent which disappears? So if in a malignancy you put the stent, all those complications of granulation infection, foreign body can be mitigated. And the biodegradable stents have come out, not in India, we have to get them from abroad, which are now also being used, a space we need to watch out, which is very interesting and very provocative. So to summarize the whole talk in the talk time we had, airway stenting, good for large airway obstruction, trachea and main bronchi. We have silicone and metal in India. Hybrids are not common over here. We prefer metal in malignancy by and large for multiple reasons. And the technique of flexible and rigid has been mentioned for the type of stent. Complications we dwelt on in length can be challenging and life-threatening. So you have to be very cautious in your decision making and in your procedure and follow-up. This is a paradigm shift in the treatment of malignancy patients. Funnily, people earlier used to not do cancer patients, but here more the symptoms, more sick they are, more the benefit. It is a paradigm of contrast over there, which we have to reconcile and adopt in our practice. Metal, it's not too difficult to deal with complications as long as the indications are correct. Please remember, plan well for both short-term placement and long-term management of these patients. Also remember that sometimes when you open, you may not need a stent for everybody. If the patient outlives the planned stent duration, you need an exit plan, either manage the complications or get the stent out, something which you have to think on as you develop your stentology intellectual quotient. So to summarize the whole talk, airway stenting is usually a last option, which is done in the way we mentioned. Surgical approaches are paramount, but in malignancy, often we are the option of last resort, and that is why we got to know this very well. Technique involves decision making. Also, A's biggest point: can I open the airway? 2, is it a good candidate? 3, after opening, do I need a stent? And more importantly, what is my exit strategy and management strategy and follow-up strategy? As we keep on saying, stenting is just the beginning of the story and has to be put in the context of first a comprehensive interventional pulmonary strategy and secondly a comprehensive multimodality strategy to do good to your patients, because ultimately we are not trigger happy people. We like to give stents only for people where it's absolutely required. With this particular message, we end the talk. Thank you very much for calling us again, and hopefully this has met the requirements.
Available and the techniques by which they are introduced. And I think we will take the questions at the end, as Dr. Rajiv Goel had suggested. So if Dr. Pattabiram is ready, then we can go on with his talk.
I hope it is ready.
Yeah, thank you. We all hope to.
Okay. Good. So this is going to be slightly on the reverse. Ravi has clearly explained how he, managed all the cases and some complications as well. What I'm going to do is, try and look at the nuts and bolts. Can you go further, please? Yeah. Next slide, please. So Stent is a prosthesis which is placed in the trachea or bronchus or both. So when you have a tracheal thing, it will be a tracheal stent. If you have a bronchial thing, it's a bronchial stent. And if you have both, covering both, it is a Y stent. Next slide, please. And it's made of either a silicone or a metal or biodegradable metal. These are the material. These are the three things. Biodegradable in India is very, very recent and nascent. So let's concentrate on silicone and metal. Next slide, next click. Metal is self-expanding metallic stent where a single woven nitinol, which is an alloy, is compressed, and it can be either uncovered, partially covered, or fully covered. Next slide. Next, please. So again, it can be a straight stent or a Y stent. There are also J stents and T stents and so on, but the most common will be a straight or a Y. Next one. So who needs a stent? A patient who needs a, tracheobronchial airway is robust because of a cartilage. So a patient needs a scaffolding to support either a weak tracheobronchial tree, wherein the cartilage is damaged, which is in tracheobronchomalacia, or a compressed due to a malignancy or any other lesion, which is an extrinsic compression, or if there is a hole in the airway. These are the three reasons why you stent. Next. So look at the indications. That can be malignancy and benign. Keep clicking. Keep clicking. Next, please. So in malignancy, Dr. Rajiv has clearly said, next. Keep clicking, please. Extrinsic, intrinsic with extrinsic component, and next, a tracheoesophageal fistula. So all three things are possible in malignancy. And benign, you can keep clicking, sir. As I said, click, just keep clicking. Next, please. So in benign, there is a post-intubation tracheal stenosis. Next. Tracheobronchomalacia. See, in tracheobronchomalacia, we don't use a stent. Yeah, you can keep clicking as I speak. So tracheobronchomalacia is as a bridge to surgery. So you put in a stent and then see if the patient is improved. And if he is improved, then you do a surgery. In tracheoesophageal fistula, especially in benign cases, it is only a bridge to surgery. It can never be a long-term process. In tuberculous bronchostenosis, we actually open it up and see if it's open. And if it is open, we leave it at that, because ideal is not to do any stent. If there is a collapse, again, we try to put in a stent if possible. Post-surgical airway issues, again, in benign thing, and post-transplant are the other reasons, but we'll concentrate on malignancy here. Next, please. So this will be what Dr. Rajiv said. So in the picture, there is a total intrinsic, wherein there will be only debulking, whereas in the second and the third, there will be a role of stenting, because the airway is collapsed, so you'll have to place this stent to keep the airways open. Next. Or in a tracheoesophageal fistula, which this is a malignant esophageal fistula coming from the esophageal side. So these are the malignant reasons why we do a stent. Next. So how do you choose the best stent? The best stent is something that you do not place. This is a statement to say that you don't really put in a stent in a jiffy. You'll have to exhaust all the options and ensure that the patient earns for a stent, because once you put in a stent, then it is just a start of the problem. Ravi just briefly alluded to. Keep clicking, sir, so that we'll finish the whole thing. Can you just keep clicking, because it's, yeah. So when will you put in a silicone stent? In a context of malignancy, you can keep clicking, sir. In the context of malignancy, silicone is done only when there is a benign or a slow-growing malignancy, typically a thyroid tumor. So if you have a slow-growing tumor, but there is also significant weakening of airway and you want to support it, you put in a silicone stent. Why? Because it's easy to remove it if you feel like removing if there are any other problems. And also because a metal stent, the reason why you put in a metal stent is you think that the longevity of the patient is going to be only about 6 months. Because the stents are designed and these nitinol gets tired after that, we can have complications. So this is purely for a stipulated period of time, whereas a slower growing malignancy, the stent can outlive the purpose. So you might have problems because of complication of stent. So in a straight or a Y stent, you actually silicone can be straight or Y, and you use it predominantly for benign lesion. And if it is in the malignancy, it's a slow growing malignancy, you'll use technically a silicone. When do you use a metal? Metal is used when there is a malignancy, and in cases of transplant, we have uncovered metal stent. I mean, that is because, you know, in a metal can be covered by another silicone layer. Why do you do that? You do that because if there is a malignancy, it can grow in, because if there is a lot of area between the wires, a tumor can grow in, so it serves no purpose, excepting in transplant where you want that, you know, a little bit of growth so that it can cover a dehiscence. Only in that setting you use an uncovered metal stent. Rest of the time you use a covered metallic stent only. So indications for metallic stents are invariably malignancy, post-transplant, and in some cases of TB bronchostenosis, when you cannot put in we cannot dilate enough for a silicone stent in place. So to, you know, choosing the best stent, it depends on the indication. If it is a malignancy, if it is a fast-growing malignancy, you would rather use a metal stent. Next. So this is a silicone stent, and you can see that there are studs inside this silicone stent. This will help in preventing the migration, but still silicone stents can migrate. And next. This is a metal stent. We are showing a covered metal stent here. A covered metal stent this is a single woven nitinol, and it is covered by a PTFE or a silicone membrane. It's easy to deploy, difficult to take it out. Next. So metal stent, which is what I'm going to concentrate a little bit. There are different companies in India. You have Automed, you have Bona, Unity, you also have Aero Stent, and you have Boston Scientific, which is partially covered. Next. So usually a metal stent will come with this, you know, a pack which has all these information. So you have an information about what is the length of the stent, which will be in a 30 millimeter, 34 millimeter, 43 millimeter, which means the stent length is around 3 centimeter. Typically for a main bronchus, the left side you use the 3 centimeter, right side you use the 2 centimeter, and in trachea you can use up to 6 centimeter. It depends on the number of you know, cartilages you want to cover or the area you want to cover. Typically, when you put in a stent, you'll have to ensure that at least 1 centimeter on either side of the pathology is covered, so that the waist of the stent should have an area above and an area below, which is normal, so that the stent is covering or straddling on both sides. You also have a diameter of what the stent deployer is and all that. And these are very important to know what are the conduit you're going to use and how it is going to go in. Next, please. So how will you deploy it? In a self-expanding metal stent is deployed with flexible bronchoscopy only is enough. It is deployed under vision ideally, though radiologists have also used it. It's technically easier, and also you're more sure when you have a bronchoscopic vision also. It is ideal to have a conduit, preferably a rigid bronchoscopy, but it can be done without rigid also. There are two ways in which it can be deployed. There can be a thread, which if you just pull it, the stent can open. It usually typically opens from distal to proximal. You also have a sheath which actually can be pulled using the deployer, and the stent opens from behind, I mean, from distal to proximal. The advantage of a metal stent is, even if you started opening it, if you want to you want to adjust the position, you want to pull it a little more, you can actually do it. So this is easy to reposition. Even after it is fully deployed, you always deploy it a little farther, little distal, so that you can easily pull it. You can never push these stents. So it's very important that you place the stent initially, deploy the stent a little distally, and then pull it up. Next. And removal is, when do you remove a metal stent? Next, please. You can keep pressing, please. Just keep pressing and fill the whole thing. So when you remove a metal stent when you have someone else placed for a reason which has actually got better, or is not required, or is not placed properly, or when placement diagnosis was not known, initially thought of as a malignancy and subsequently it was not malignancy, or when you want to remove it like in a tuberculous bronchostenosis. These are in benign condition. Next, in malignant condition, when do you remove? When the patient has outlived the stent has fractured, or stent stopped the purpose, so you'll have to remove it. And or the stent has been outsmarted by the disease, or new complications related to the stent, like a TEF beyond the stent. Next, I think the complication was also addressed, by Dr. Ravindra Mehta. And this video will tell you how metal stent is removed. Can you play the video on, please? So this patient was put on a metal stent, and we had to remove the metal stent. You can see all the complications that Ravi mentioned also. There is a biofilm, the stent looks ugly, and the stent was put for a fistula, but you can see that the fistula, which is an esophageal malignancy, the fistula is actually expanded, and what you see on both sides of the carina and what you see on the 6 o'clock position is the stent actually digging deep and burrowing the the damaged airway, and you can see that there is a huge fistula now. We have to remove it and put in a Y stent. Next, please. And this shows how a stent can be removed. The metal stent has to be removed with rigid only. So you can put in without any rigid bronchoscopy. You can use put it with a flexible bronchoscopy. But for a removal, whenever there is a complication, you will need to have rigid scales. Next slide. And this is how a metal Y comes out. There is a right wing, which is a right limb, which is a shorter limb, and there is a left limb, which is a longer limb. And you'll have to, ensure that the right goes into the right and the left goes into the left. For that, you need to have fluoro also. So metal Y is a difficult stent to put in. And I think Ravi showed a video of that also. Next slide. And I think complications has already been dealt with. There are immediate complications, and then there are long-term complications. Migration, non-deployment, proximal deployments are immediate. Intermediate is when there is a granulation or a fatigue or a fracture of the stent or a tracheal fistula, and a long-term is difficulty in taking the stent out and tracheal cartilage damage. Next slide, please. And this is one case where there is a stent fracture. Can you click on the video? You can see that the stent, which is supposed to be, completely covering, you can see on the posterior, it's just lifted up. That is because the stent was fatigued and it got into a fracture. And you can see there are two segments. One is the right hemisphere and the left hemisphere. And the patient had a significant cough after the stent fracture developed. The fracture of the stent typically happens after a few months of stent. And this is the reason why you have to take it out. Next slide, please. Next slide. I think we've shown this again. We don't need to go through. And in silicone stents, next slide. It's either straight or Y. It's always deployed through rigid bronchoscopy. So for silicone stents, you'll need a rigid bronchoscopy skills. And anything more than 13 size, which means in trachea, you'll need to have a bigger size. It'll be 14 or 15 or 16 or up to 18. We don't use 18 though. 16 or 15 is a tracheal thing for adult. It requires a size 14 rigid barrel. See, 14 mm barrel has to be put in, and even that is not enough. See, silicone, unlike a self-expanding metallic stent, it can only be folded. Despite folding it, you can, you need a large barrel for you to put even that folded stent inside. And so you need to have certain applicators, and the deployment is usually blind. The stent length can be customized on the table, and that is the advantage of silicone stent. So you have a smaller lesion, you can actually customize the stent, you can reduce the size, whereas in metal stent, it comes in a certain dimension that you can't really alter. Experience and eyeballing are the best way to predict the diameter. Repositioning and retrieving is easily done with the rigid skills and appropriate instrument. And this is a big advantage for a silicone stent. Next. And a silicone Y, again, in a carinal lesions, which is a long-standing thing like a slow-growing tumor like adenoid cystic, the deployment can be tricky. I need to customize the right limb to ensure that the upper lobe doesn't get cut off, and deployment again is blind. And you'll need to have a good amount of experience to get into silicone Y stent. Next. And again, the complications has been dealt with. Keep clicking it. Just to reiterate, there can be an immediate complication. The most important complication, especially in the straight stent, keep clicking, sir, is the migration. There can be inability to deploy, which is a technical issue, and probably by experience, it should be all right. Sizing issue is usually an important thing. If the stent opens immediately, then that means it's undersized. The stent has to open with difficulty, only then it will not come out. Migration is a huge issue. Intermittently, there will be an intermediate thing, there will be a halitosis and thick secretions. It has to be maintained properly, and you need to have a follow protocol for that. An intractable cough, because it's a foreign body, any stent can cause this. Long term can be granulation, and a biofilm which can cause secondary infection. So these are the reasons why you would also remove it. Next slide. These are one of the stent that was removed. The good thing is it has no mucosal changes, so it's ideal for long term, and it's usually a bridge for surgery. So because when a stent is done, it doesn't affect the mucosa. The mucosa remains pristine. So even if the surgeon wants to do any procedure, once you remove it, immediately the airway is good enough for the next procedure. Whereas a metal stent, especially the uncovered ends, can actually dig into the mucosa, cause irreversible changes, and at times what would have been a surgical things, once you put in a metal stent, especially the uncovered portion, if it is significant, it might change a operable lesion into a non-operable lesion. So you'll need to be very careful and responsible whenever you choose the stent. Next slide. You'll need to know all the advantages and disadvantages. To summarize, stents are an important aspect of IP. Stents are life-saving in emergency situation. You have to choose wisely between metal and silicone. A good rule of thumb is for malignancy and aggressive lesions, metal is good. When you suspect a slow growing, or when you suspect that you are in a situation where you might have to remove it, typically is when there is an extensive compression because of a lymphoma, which is compressing it, and you know that with treatment it's going to get better, drop a silicone stent because it's easy to remove it after that. Always comes at a cost, and always remember the initial thrill is short-lived. Have to face the short and long-term consequences. Once you stent a patient, you're literally married to that patient. Patient can come in with the breathlessness, with a clogged stent at 6 p.m. at Saturday, and you'll have to put everything together, and you'll have to open the suite, and so it's a 24/7 thing. So I think that these are just a few points to know about stent, and so I'll be happy to take any questions regarding this. Thank you, Rajiv, and
thank you very much, Dr. Patabi, for a wonderful exposition on the variety of stents that are available to us and how you deploy them, and also the immediate and intermediate and late complications. So having said that, there was a question from the audience. I don't know who would like to address this, but how do you ventilate these patients when they are using a flexible bronchoscope?
Okay, so when you the typical way of doing a flexible, which is a self-expanding metal stent, is the patient will be sedated. Ideal to have a conduit, and if you have a conduit like a rigid bronchoscopy, it is easy. When you have a rigid bronchoscopy, ventilation is ensured so that you can do your work without a problem. Now, what happens if you want to do it without a rigid bronchoscopy is, first thing is you put in a bronchoscope, and then you put in a guide wire inside, and they take the bronchoscope out. So after that, the patient will be having only a guide wire. So the patient has to be spontaneously breathing. He can be mildly sedated, but he has to be reasonably awake. I mean, with the sedation, we can do it so that the patient breathes on his own. This will be a challenge when there is a patient who is actually having a compromised airway because of the primary problem. And you're putting a stent deployer, which is at least a 5 mm thing. So for that, duration where the stent deployer goes in, you deploy the stent and you come away, that duration, which can typically range between 1 to 3 minutes, that time the patient will not have a lot of airway to really breathe. So it's a challenge for you, an anesthesiologist, and so on. This is the reason why we use a rigid bronchoscopy, so that you actually right away ensure that the ventilation is taken care of. But if you don't have a rigid bronchoscopy, usually you can get away when you have an experience in using these things. Now, another thing is, if you for all the stents, we also use a bronchoscopy on the side to see and deploy, so that you deploy it properly. You can also not use the bronchoscope and use purely fluoroscopy, in which case the number of instruments that goes across the vocal cord will be a lot less. That might help his ventilation. I would have Rajiv's input on this.
So can you hear me? Yeah. So basically, I think Patabi said it all, but broadly, if you divide the patients into two, that means that one are patients who are relatively unstable. So patients who are in distress and who are unstable are probably, preferred. The preferred route would be to control the airway with a rigid bronchoscope and then do the stenting. However, if the patient is stable and, is able to breathe on his own well and is not in, frank respiratory failure, then that is the kind of patient you could, attempt with flexible bronchoscopy, because he is the type of patient where he will be able to withstand that very brief period when we got the deploying catheter as well as the fiber optic bronchoscope inside. And my feeling is it's a question of selection of the case. So if you select carefully and take those patients who are relatively unstable straight away for rigid bronchoscopy and stenting via the rigid bronchoscope, then you are then you made a correct choice. However, if the patient is stable, then you can do it quite safely with the fiber optic bronchoscope.
Another question from the audience: what is the maximum duration of keeping either stent, the metallic or the silicone stent?
So as I said, long-term silicone is better. In case of metal, you can keep it as long as it doesn't cause any problems. If it has a problem, you'll have to take it out and be prepared to handle the complications. If there is a granulation, you'll have to remove that granulation, and then if there is a requirement, you might have to put in another new metal stent again. So generally, the duration depends on the indication. The reason why FDA gave this instruction is, pretty early. I think it's early 2000 is when 2005. I think when FDA gave a directive saying if you're planning to put in a metal stent, it has to be only in case of malignancies. If there is not malignancy, you will have to exhaust all the other options, including silicone stent, and only then you apply a metal stent. So that was in 2005. But the duration of how long can the stent stay in, as long as it doesn't cause problem, that is a straightforward answer, and as long as it is required for the stent to be there.
Dr. Goel, sir, how do you overcome the challenge of introducing the barrel of the Dumont stent through a smaller Indian laryngeal aperture?
Yeah, so that can be a problem at times because, we've had occasions where you are intending to put a silicone stent, but the patient is, too small. Under those circumstances, sometimes it can be impossible, and you may have to choose a self-expanding stent instead of a silicone stent, and then be ready to change that stent as and when required. But if you are skillful, then usually you will be able to manage with the rigid bronchoscope in most patients. But there have been occasions where if you have a very small patient, then you may have to choose a different type of stent. I remember reading one paper by the PGI people where they actually dilated the airway a little before they were able to put the rigid scope inside and then put the stent. But that is actually pun intended, stretching things a bit.
Dr. Patabi, when do you remove a silicone stent in a benign lesion?
So if it's a post-intubation tracheal stenosis, there are very clear guidelines. Now you put in for with the purpose of, if it's there are two types of post-intubation tracheal stenosis. One is a simple, another one is a complex. We'll have to look for option of surgery. Now, if the patient doesn't want a surgery, or if the surgery is not possible, or if the patient is too sick for a surgery, you put in a silicone stent. End of 1.5 years, you remove that stent and see. About 30% of them will stop requiring anything further. So you remove that by around 18 months. Now, if the patient has a problem again, then you'll have to either put a silicone stent again, because you're looking at a long-term thing. And then you just see if it is feasible at that point, because the patient will be much better for a surgical option. So this is in terms of a post-intubation tracheal stenosis. That's the most common thing why you'll put it in for. Now, in case of a malignancy, as I said, if it's a lymphoma, you put it till the chemotherapy acts in, and after that you just remove the stent, which is the duration will depend on how the patient improves and the CT improves. So the duration will depend on that, and it's usually faster than 18 months. You don't need to keep that. In transplant scenario, you're supposed to remove any stent in 6 months' time, and see if there is requirement, you can put additional stent. That's why in transplants, they're using more of a biodegradable stents and so on these days. So transplant scene, you're supposed to take it even before 1 year. It's roughly around 6 months, and you remove the stent if you put in a silicone stent. If it's any other things, you remove it for complications.
Okay, Dr.
To add to Batavi's point, it actually is either indication or complication. Two things decide stent removal. The indication is data-based and complication is observation-based.
Okay, thank you. In the malignant mixed,
joined by Dr. Ravi Mehta also. So if there are any questions, Ravi, why don't you show us, become more visible and so that.
Ravi, I have a question for you. In a malignant mixed central airway obstruction, who may respond to chemo or RT, which stent do you use as a bridge to therapy, a silicone or a metal stent?
If it's a short duration, see, all the criteria we use in our lectures is what matters. First of all, it's the indication which you're talking about. Secondly, is the technical aspect which we discussed at length. And thirdly, is the exit policy. We have to be very anti-Bush type because we have to exit in time without causing complications. So if it's a short-term thing, silicone ideal because you want to take it out and it's easier to take it out. But on the other hand, if it's not possible or you cannot do silicones because of rigid, put a completely covered metal, but get out as soon as the job is done. So if chemotherapy has reduced it or the mass is shrunken or so on, radiotherapy has been used, you can take the stent out. So completely covered metal stent or silicone stent, both are efficacious as long as you have a window which is small and you plan to have definitive resection after that.
So what is the follow-up that you suggest, follow-up protocol after stent placement?
So there's nothing definite mentioned. What's out there is that for silicone stents, since we talked of secretions and clogging, nebulization with saline is recommended 3 times a day assiduously, especially in India when you have such high temperatures like 45, 50 in the north and so on. It's very important you prevent dryness and crusting of the stent. The second care, the metal stents part of it is by and large, again, keep humidification going and nebulization may be given or MDI with spacer so as to maintain secretion movement. The third thing is obviously stent removal. You can't keep them indefinitely. The only problem is sometimes patients disappear on us. And India is full of stories where this guy came after 5 years, 7 years, where you have a nightmare pulling out the stent. In terms of bronchoscopy, surveillance bronchoscopy is indicated by and large for clinical indications. So if you have a reason to suspect that there is obstruction, granulation, and so on, otherwise there's no clear guidelines. We are a little more cautious. For example, why stents for clogging is more often, we'll often suggest a monthly check bronchoscopy to clean up. So it goes clinically. In short, nebulization with saline for silicone, good airway clearance with regular inhalers for not ICS, only beta agonists can be used for metal, bronchoscopy surveillance as needed, and exit policy to be definite.
Dr. Shyam, I think we are 25 minutes late, so we should conclude this session.
Yeah, I think we should. I would like to thank all the speakers for their wonderful presentations and also highlighting the importance of central airway obstruction, the algorithm for approach, immediate versus late management, and the various stents at our disposal, their complications, their deployment, and the exit policy. Thank you very much. I would like to thank the organizers on behalf of both of us, Dr. Arun and me, for giving us this opportunity to chair this session. Thank you.
Thank you.
Thank you very much.
Thank you.
If any question is left, the speakers can write it on the chat box so that things are clear to the...
Thank you, Arun sir. Thank you, Shyam Sundar sir. With this, we continue with our next session. I would like to invite chairpersons, Dr. Karan Madan and Dr. Sanjay Sharma. I request both the chairpersons to introduce our next speaker. Moderator.
I think Dr. Sanjay, you're on mute, I think. You're trying to speak.
Yeah. Yeah, thank you very much, Ullas and other friends. Nice to see you all there after long. It's been really an exhilarating presentations. Reminds me of my days at Tata Memorial when I used to do all kinds of the jugglery when the damn things were not available, including coring off and intrabronchial radiotherapy, which we have published quite a lot. Me and my friend from radiotherapy department. So now we have come a long way and we have better things to do. And obviously fantastic drugs where Ullas Batla doesn't allow you to use anything. This damn chemotherapy and immunotherapy dissolves everything. So anyway, come to the point. Now I invite the first panelist here. Sorry, it's a multimodality treatment and the moderator obviously is Ullas. And is Ullas around? Yeah. Yeah, I can see Ullas. Hi, good evening. And Ullas, would you like to call the panelists yourself?
Yes,
that
sir,
would be fine.
I can. So
Okay.
can I please share my screen? So in the meantime that I share my screen, I will have a question, which can I ask Dr. Rajiv Goel, sir? Sir, can you please show us your face while you answer this?
Yeah.
Okay. So my question over there to all the interventional pulmonologists and you in general and you in particular, sir, how many marriages are interventional pulmonologists allowed, sir? See, when you put a stent, you are married. So when you put a stent, you are married to the patient. When you put an IPC, you are married to the patient. When you control the hemoptysis, you are married to the patient. Sir, हो क्या रहा है यहाँ पे, sir?
So we have more marriages than we can handle by far. Karan, you can see Karan in his young age is already started looking old because of
I
that.
know. Is that the reason, Dr. Karan, that you took up interventional pulmonology?
Sir, I'm done after one, sir. So
Just call for a uniform civil code.
Okay, so this is a great session. This is a great meeting, and this is an ideal tumor board that we actually have. So we have three medical oncologists: Dr. B.K. Smriti, we have Dr. Shekhar Patel, we have Dr. Mansi. We have one surgeon. Dr. George is enough for all of them, I guess. We have four pulmonologists. I think Dr. Sachin, Dr. Mahima, Dr. Jeenam. And we have two interventional pulmonologists, Dr. Shetty and Dr. Abhishek Bansal. So that's a fantastic plethora of panelists that we have. So my first reactions when I actually thought about panel discussion on this stents in lung and thoracic cancers, and when I did search was stent in coronary artery, and then the stents over there. And I actually thought I'm pretty sure I'm in the wrong meeting. And I said, where is it? I mean, that like Dr. Sanjay Sharma said, we give oral tablets and everything and things are okay. My subsequent reactions over there, I'm actually in very good august company. So let's make the most of it. Let's learn from them and let's get the best for our patients. So let's start with stenting in thoracic cancers. And as obviously we have 6 questions. My first question is for the end user. I mean, this is a malignant, we are all lung cancer experts over here. So let's take the end user, the oncologist perspective. The pulmonologist had a field day in telling us all about the stents and everything. So let me start with Dr. George and then to Dr. B.K. Smriti. Sir, what are the most common malignancies in which stent is usually inserted in your clinical practice? Out of 100 patients that you see, let's say 1,000 patients in case of Tata Memorial people that you see, how many did you put in stent earlier on, and how much has the frequency increased or decreased as before?
Yeah, so we do use stents quite often, but sparingly. I don't think the rate of introduction of stents increased over the period of years. But surprisingly, if you think we place stents maximally for lung malignancy, it's not so. The most common indication, I just checked our database in the last 3 years, most of them have been placed for esophageal malignancies, upper third with bulky lesions with extrinsic compression, nodal masses, mediastinal masses, etc. Most of our endobronchial growths from lung cancers or other minor salivary gland tumors have been done with endobronchial interventions like debulking procedures, but very few of them have actually required stents. We do use stents sparingly because if they survive long, we have more problems with the stent than with the disease.
Okay, so basically esophageal malignancies are the most common things which you actually use. Let me ask Dr. Shekhar Patel. Dr. Patel, sir, how are things in Bangalore with this?
Yeah, basically, sir, the usage is there, but with the improvement in the technologies in radiotherapy and chemotherapy, immunotherapy, targeted therapy, we use in a very selected patients. First is we start up with these treatments which are effective only when we feel that the obstruction is not getting relieved. Then only I refer to an interventional pulmonologist for putting a stent. Otherwise, generally, I don't use it upfront directly, even if I find a patient, except in a patient who has got a tracheal obstruction where I want some results immediately. Otherwise, generally, I go slowly, sir. That is all I can say.
Okay, so that brings me to a very important question. I'll ask Dr. Mansi. Do you think does the biology of the disease trumps anatomy, or do you think it's the Dr. Shekhar Patel and when Dr. Pataraman was showing, he showed those the third photograph in which you have a tumor which is actually compressing upon the upper lobe bronchus and it's also infiltrating. but it is an ALK positive non-small cell lung cancer, or it is a small cell lung cancer. Would you give yourself a chance first with your chemotherapy and ALK TKIs, or will you involve the Dr. Rajiv Goel's services to start with there?
So yes, biology does trump anatomy sometimes, especially in tumors where we know that they're going to respond beautifully to whatever treatment we can give them. Having said that, I mean, small cell lung cancer, especially maybe in the first line setting, if a patient first comes to us, if it's not an urgent, immediate, life-threatening medical emergency, I think other than that, yes, I mean, we would probably want to give chemotherapy first, stabilize the patient first, because we know that the disease is going to respond very nicely.
Okay.
Similarly, you know, say a mediastinal mass like a lymphoma or a germ cell tumor, anything that we feel that will respond nicely.
You think that the biology trumps anatomy? I will not agree with you right now, since I'm the moderator. And so the point here is, let me ask the pulmonologist. So let's say, Jeenam, you have, you know, let's say the good old times when you were working with us, the good old times for you, when you were working with, when we were working together. Jeenam is there?
Yes, sir. Yes, sir.
So let's say you have a patient you think you can easily stent, but your medical oncologist over there says, come on, yeah, it's an ALK positive or a small cell. Let me give chemotherapy first. What would your reaction be to that?
Everything depends on the patient first, I feel. If the patient is obviously in dyspnea, patient is not able to, you know, lie down flat, patient is in stridor, then obviously whatever the biology is, whether it is a very beautifully sensitive to chemotherapy or not, we have to give priority to the patient first, tend the patient, and then easily he can accept the chemotherapy, whether it
patient
is
maintaining 93% saturation on DEXA 8 mg BD and some oxygen 3 liters per minute.
So patient on oxygen, so that is obviously, I would say that patient would probably, I would be better off in starting the patient on, putting the patient on stent, because immediately after putting the patient on chemotherapy, the patient is not going to have an immediate response. It's going to take a few weeks before.
I mean, that is what I wanted, Jeenam. That is exactly the point of discussion that I wanted. Dr. Smriti, Dr. Karan, welcome to you later. Dr. Smriti, madam, a small cell lung cancer, we do expect, and you know, we have got people out of ventilators from ALK positive, this thing. So what do you think we should do? I know there is no right answer for this, man. We're just learning from each other.
Yeah. So as you said, there is no right answer over here. And, you know, when I began my practice, we had very few options for these patients, but now everything has changed. So not only has the intervention part has changed, but also the therapies. So, you know, most of the times, like a case that you mentioned, small cell lung cancer, we know that they respond very fast, or a lymphoma. So it would be a very balanced decision not to stent and start the therapy. But, you know, some cases that which I have seen where we have had to put a stent is especially the tracheoesophageal fistulas in esophageal cancer, because there, you know, it's going to take some time for these patients to respond. Otherwise, you know, in non-small cell lung cancer, where, you know, you have very good therapies, you try to stretch as much as possible before you ask the pulmonologist to actually intervene.
Okay, so the medical oncologists are sticking to their guns that, you know, we will go in first and then we will give you a chance at that. We are sticking on to that. Let me ask Dr. Karan. Dr. Karan, you had a point.
Yeah, so I think I would like to say that it's not a, you know, a war of turfs between an oncologist and a pulmonologist. A 93 saturation does not actually mean that your patient may be stable, because respiratory failure can actually, you know, not be, you know, represented by hypoxemia alone. So patients may have, you know, a central airway obstruction. He may be impending respiratory failure, but maybe maintaining saturation. But he may be having, you know, flaring of allanesi. He may be having, you know, signs of impending respiratory arrest. And sometimes you have a situation in which you don't even have a tissue diagnosis.
Yep.
So a patient has come with a, you know, an obstructive lesion. You don't know the tissue diagnosis. And then you have two things in mind to actually, you know, so I would think that, you know, regardless of a biology, it's the patient's clinical status which matters. If it is, you know, an extrinsic or a mixed lesion, patient is in respiratory failure, impending respiratory arrest, you know, give him an interventional procedure, get rid of the central airway obstruction, and, you know, stents can be removed. The problem which we do is that we delay the removal sometimes also too much. You know, sometimes the patient has responded to your medical treatment, but it's like the stent is there, it will stay on. So I think those are the kind of things which you need.
Bhul gaye. Medical oncology wale bhul gaye, pulmonology wale bhi bhul gaye usko.
Can I just say one word?
Yes, Dr. Rajiv Goel, and then Dr. Sanjay after that.
Just to reiterate what Karan is saying, that the in many a times the anatomy becomes very important. If you've got a patient with a major collapse of one lung, or you got a patient with obstructive pneumonia, you would want to allay that first before you start your chemo, because that is actually going to complicate matters for the patient.
Okay.
So it's a question also of actually seeing what the obstruction is doing to the lungs before you take a call as to So it's not only the biology, but
It's the biology and the anatomy.
And the anatomy.
And the anatomy. Okay, now Dr. Sanjay Sharma and then Dr. George. Oh, come on. I never knew my first question only will derive so much of discussion. Dr. Sanjay, sir.
Yeah, actually, George summed it up very much. And the time has now changed totally, in my personal opinion. Previously, in a thoracic cases where there were hardly any treatment available, not even the stent, with great difficulty later on. As I mentioned earlier, was to core the damn thing or burn the damn thing and put in radiotherapy local. But the times have changed. Now, lung cancers do not really come to us with a lesion or a tracheal tumors are not very common, though few rare ones, maybe going to George more often than to me now. For me, the large, bulky tumor, lung blocking the thing. For me, if the condition vis-a-vis in terms of not only, as Karan really rightly put it, my worry is he drowning in the secretion? Is he having a severe blocked bronchus giving us to a bronchopneumonia, which Dr. Goel mentioned? Those are the cases probably I would rather, if this impossible bronchoscope situation, I'll put in a stent, and I would agree with Gina and other places. And Gina is my colleague at Kambala Hill with me. We do that occasionally.
Okay.
But in lung, yes, it is less numbers than what we get in esophagus.
Okay, Dr. George.
Yeah, but I think when I took all the points mentioned by the panelists are important, but I think you hit the nail on the head with the question about biology. I hate using the word never, but to date, I've not stented a patient with a small cell or a lymphoma. Chemotherapy works well. But to the other side of the question is in a non-small cell lung cancer, I don't think I've ever seen chemotherapy act fast enough to allay an airway obstruction. You would need a stent in most of those cases.
Dr. George, I have 2 points on this. The point is it also depends on the expertise of the pulmonologist. With not every center has people of great this thing. Now, my concern over there is, let's say you have a small cell or you have an ALK positive non-small cell lung cancer, and then you did stent and something goes wrong, and things do go wrong. The medical oncologist is going to curse himself, not the pulmonologist, himself. We'll always have that guilt that maybe an oral tablet could have been given. That's the point that the medical oncologist, because the drug Alectinib has a 80% response rate. It starts responding within 7 days, sir. Now, my point, if we can avoid that, should we not avoid that? That's why we are saying biology is trumping anatomy.
I completely understand your question in terms of peripheral airway obstruction, where 7 days is adequate time. But when you talk about central airway obstruction, the trachea and the main bronchi, with a patient in stridor, I think those 7 days of value and probably a stent is a more effective procedure in the short term.
Okay, fair enough. Dr. Shetty, I did ask Abhishek whether there are any question that I should ask a pulmonologist, interventional radiologist. Any radiological signs, that on the CT scan, then when you call up your medical or surgical oncologist and tell that you do require to send this clinical condition, yes. Anything telltale signs on the scans?
Okay. Are you able to hear me?
Yeah, we are.
Yeah, right. So the question would most of the time come from the other side, rather than we seeing the CT and then calling up the clinician telling that that is critical narrowing, which requires stenting. The call would first come from the casualty, telling that there is a patient who is in stridor. So can you please fast track the CT scan so that we can take a call on intervention or regarding stenting. So on CT scan, yes, you see that it is.
Dr. Shetty, then let me ask a different question.
Right.
Between interventional pulmonologist and a radiologist, let me open the Pandora's box. Whom should I refer to? The one who's available earliest?
I think at least in TMH, I can say that we work as a multidisciplinary team. So invariably, you give call to a to a surgical oncologist or to a radiologist. At the end, once a scan is done, all the team members would be intimated. So I think Dr. Mahima also is there in the panel, and she would agree that if the patient is decided to be intervened, so it will be a surgical oncologist and the pulmonologist, we from the IR, and also thoracic anesthetist.
So can I ask Dr. George, Dr. Nitin Shetty, and Dr. Mahima, sir, how do you decide which one goes to Dr. Shetty and which one goes to Dr. Mahima and which one you take over, sir?
So actually, Nitin hit the, it's completely a team. I'll get to the point of first intervention is usually the surgeon, because the patient reaches a casualty and the person who responds fastest is usually the surgical team. And we have a massive team. So
we can discuss on that later, sir.
Yeah.
The surgeon responding first, we can discuss later, sir.
But the moment the scans are done, then it's put on, we have a WhatsApp closed group with the anesthetist, the radiation radiologist, and the pulmonologist, and the surgeon at C2. And then we work as a team and get the patient mobilized.
So that's
and the logistics is the most
one, sir. Sir, tell me as a rule of thumb, sir, which one goes to whom, sir?
Oh, it's. I'm sure you're going to get the same answer from all four. It's all of us together.
Okay, fine. You're not budging from anywhere. Okay. So let me ask what happens later on. So let me ask Dr. Smriti or Dr. Mahima also. Madam, any concern regarding giving radiotherapy after stents insertion? Let's say you have got a tracheoesophageal fistula and you have inserted the stent. Sometimes dual stents are there. Any concern, and the lesion is localized? Would you give RT after stent insertion?
Well, if there is already an existing tracheoesophageal fistula, I would not like to give radiation. I mean, I would like to start with systemic therapy, because my experience.
Ma'am, let's say we have given systemic chemotherapy, the disease has responded, okay, and now
then we would then of course once it has responded and the tracheoesophageal fistula is healing, then we would send it to the radiotherapist, because most often the radiotherapist colleagues would say that if they started radiation right away, it may get worse.
So you will say chemo, or Dr. George has a point. Dr. George, sir.
I completely agree. We do give radiation sometimes after placement of stent, but it's a very dangerous thing. Nitin will vouch for it, because we had two patients whom we placed a stent after radiation. One a metal stent and one a Dumont stent, and the stent just eroded through the trachea. So radiation and stent is a dangerous mix and should be used with caution. Probably Dr. Goel can opine on this, because we had a silicone stent eroding through a trachea in a patient after external beam radiation and brachytherapy. And the stent was placed when there was no disease. So,
Dr. Goel is a big proponent of giving radiotherapy. The only thing is I come between him and radiation oncologist. Dr. Goel, sir.
Yeah, so I think it's a difficult thing to.
Sir, you have by mistake you have muted your.
Yeah. Am I audible now?
Yes, sir, you are.
Yeah. So basically, I think the question is that stents eroding from the esophageal side into the trachea, and that is a practical problem. It most often due to disease, but then we have seen sometimes, even George, you may have seen patients with gastric pull-ups.
Yes.
And they erode into the, mostly into the right main bronchus, and we've had fistulas which look fairly benign, but I think it's because of ischemia of the wall, and the wall of the bronchus also gives way, and those are particularly difficult to stent, because you don't really know, and the surgeons are very shy of going back there again and repairing them. So these are practical problems, and I think the radiation people are rightly scared of these lesions, because I think that what radiation does also is that it causes significant amount of ischemia and fibrosis in those areas. So once they become ischemic, the tissue gives away very quickly.
Dr. Sanjay Sharma had a point.
I wanted to ask for George, leave aside esophagus. There the scenarios has not changed much, because the involvement of the lesion going into the trachea causing fistula. So there the question doesn't arise. Obviously, first you stent it. But George, tell me frankly, I mean, in my olden days when I was around there, We used to really give radiation therapy locally, external, then DXT was there, or maybe external radiotherapy earlier. They used to work. Unless and until the tumor was crossing across into the tracheal wall to start with, then there were fistulas and we used to stent them. And of course, that time only there was a metal expanded stents, not Dumont stent. We never used. Later on, very lately, we started biodegradable, not biodegradable, but other silicone stents. So how many of your percentage today, George, you need to stent before the treatment that you start, especially for a malignancy only of tracheobronchial tree or for that matter lung?
To answer your question, sir, from 2019 to 21, we have just placed 18 stents in the airway, out of which for lung lesions on minor salivary glands, we have done around 6. All the rest were for esophageal lesions. So the 3 stents which we placed for the tracheal stents, which we placed for airway for NSCLC, that's it. So the number of patients we do it, it's only in metastatic or locally advanced disease where surgery is precluded is the only place where we have placed SEMS for lung cancer.
Dr. Sanjay and Dr. George, Rajiv Goel sir is going to present the data of RGCI in another 2 minutes. I will give him this thing. We will show you RGCI data in the last 3-4 years. So I think we are also going to...
Ullas, you have got your answer. In lung cancer, with ALK positive, you can give tablets, don't worry. Stent may not be necessary. So, but yes, if it is a minor salivary gland or any other cancer, probably you need a stent.
Fair enough. So let me ask Dr. Sachin now. Dr. Sachin, you have stented the patient today. I call you up that I want to give chemotherapy. When can I give? Yesterday, today, tomorrow?
I would say within 48 hours of stenting, I usually send the patient for the oncologist. And even as the radiology people said, most of my patients who have underwent the stenting do have underwent radiotherapy, especially in adenoid cystic carcinoma, and they have done really well. And post-RT, there was no recurrence in the PET CT, and we have even removed the stents in a couple of patients. I remember 3 patients who are under oncology follow-up who come to me just as a routine friendly visit, just because I had put a stent and removed my stent. And I don't think so that, radiation with stenting is such a major issue, because we had a lot of patients who had received a RT following stenting. And one important thing, Dr. Ullas, I would like to say after all this discussion is, everybody is speaking about stenting in lung cancer, but I don't think so that, purely intrinsic lung cancer tumors, be it be adenoid cystic, be it be carcinoid, they need any stenting. They just need a debulking, and then I send it to the oncologist and the radiologist. Most of these patients do well with the, systemic therapy that you people give, and a lot of advancement have happened. So I really believe, Dr. What Pattabi said, the best stent is the stent which is not put in the trachea.
So best stent is the alectinib and the osimertinib.
Exactly. I do believe that the best modality is still the systemic therapy. Okay. So I only do the stenting after debulking in only very selected patients where there is a tracheal cartilage destruction or malacia, or if I believe there is an associated extrinsic compression as well.
So Dr. Mansi, let's say the stent has been put by Dr. Goel today. We ask you to give, patients are on our head to give chemotherapy. How soon? And any peculiar side effects, stentitis or something that you have seen?
So again, it depends on the patient, I would say. If the patient is stable, doing okay, no major issues, no significant, as Dr. Rajiv Goel sir only said, no significant post-obstructive, pneumonitis which needs to be taken care of, which would lead to chemo complications. I think we wait for 24 hours. 48 hours at the max. Of course, we do talk to our pulmonology team and take a joint decision, and then we can go ahead. We've done it.
24 to 48 is good enough. So I think, we all took the data, and that's very, very important. Dr. Smriti has a point. Madam, you have a point, please.
Yeah, I just want to know from the panelists, with all this discussion, you have a pleural effusion patient where you need to insert a intercostal drain. And at the same time, there is extrinsic compression distally in the bronchus and causing a collapse of the lung. So that, once you put the intercostal, then it's not going to expand, even though, your treatment is going to take time. There is no mutations in that patient. So you're going to be depending on chemotherapy and, immunotherapy, which will take longer. So what do you do under those circumstances?
So if I have understood your question rightly, madam, central airway obstruction causing
no, distal. It's a distal airway, but it is causing a collapse of the lung. So, and you want to insert a intercostal drain because of repeated pleural effusion. So, how do you tackle that? Like, you just put the intercostal drain, start the therapy and wait, or would you think of stenting?
Fair enough, ma'am. I'll ask Dr. Mahima. Dr. Mahima, you haven't spoken much till now. Your take?
So most of these would be relaxation collapses, which as I understand from what she's asking, is the compression effect due to the effusion. So the main treatment in such a case would be to relieve the effusion, which should cause expansion of the lung automatically.
No, here the obstruction is in the bronchus. It's not.
Okay, so distal airway obstruction relief is much lesser as compared. But yes, if you have a non-expanding lung because of distal obstruction, then instead of an intercostal drain, an indwelling pleural catheter would be a better option. And then assess if there is any intraluminal lesion that you can address in addition.
Okay. Thank you. Ma'am,
and I agree with Dr. Sachin, what he said, that, in most of our lung cancers, what we do, we always look at what is our indication, go for, and first look at what you can address intraluminally, and then look at the mural or the extrinsic component. And by tackling most of the intraluminal components, your, usage of stent always comes down, because if you tackle that, and you're pretty much done for most lung cancers. Yeah.
And on a very lighter vein, Dr. Sachin, that is why the friendly visits that you get from your patients are not because you put the stent, that is because you took out the stent early.
Okay. I really believe. And I think there is one more thing, Dr. Ullas, there is a lot of transition that is happening from the metallic to the silicone stent, even in lung cancers. Like what we used to describe previously is, for malignancies, usually we used to prefer metallic stents. And we initially, in the last 1 year, I might have put almost more than 20 stents for lung cancers. And we removed it immediately also. But we have encountered a lot of complications with stents. And now we are moving into a transition where even for lung cancers, we are trying to use silicone stents more.
Okay, so let's talk to Dr. Rajiv Goyal. Dr. Rajiv Goyal, can you please come on, put your video on, and we can discuss the RGCI experience in this?
Yeah, I think my video is on, and basically this is just a recap of some of the data that we fished out recently. So 73 patients where for different type of malignancy airway stents were deployed, and you can see here that mostly male patients, mostly esophagus, about almost 70% esophagus, but then they were about 10% lung carcinomas, thyroid about 7%. So different type of malignancies, extrinsic compression, most of them. And then if you see that most of them were, either tracheal stents or Y stents. So we've put in a fair number of Y stents, and my experience has been that the self-expanding Y stents have actually opened up the field significantly. These Y stents, they don't suffer from migration, and if they are well placed and the patient well selected, then you can actually give good relief to the patient. And as you can see that most of these patients were done under conscious sedation, which also means that most of these stents were put under with a flexible bronchoscope. And can I have the next slide, please?
Yes, sir.
Yeah. So here you can see that procedure-related complications, not too many, but post-procedures, yes, they can have problems of mucus plugging. They can have problems sometimes of migration, sometimes of fracture. Not too many of those, but so largely well accepted. We've been able to remove many of these stents, and post-stent infection was also a problem. So what we did was, and I think that one important aspect of what we are discussing today should also be, we should be following up these patients to see how they are faring subsequently. And I think that is a very important. So putting the stent is one part of it, but actually looking after these patients and seeing how they are faring is another part of it, which actually, is what matters more. And what we found was that when we talked to these patients, or telephonically we tried to contact all these patients or looked at their case records, we found that about 60% of them have now died. About 30% were lost to follow-up. And most of the deaths were about, you can say, survival overall after stenting was less than 3 months, was about 40%. So this is a significant number. And I think this number is important because normally when we talk of stenting, we say that a person with a stent should live at least for 3 months or more. So in that context, you can say that of these the stents that have been put in, probably our case selection could have been better, and we should look at the type of patients that we are stenting more closely. So we would wish that this less than 3 months survival or death rate should be less than what it is. It's about 40% on this particular series. But the thing is that most of the patients had more than 50% of improvement immediately, and which is important. So if you are giving more than 50% improvement to a patient with stenting, that means that the immediate job has been done. However, I think the survival after stenting depends on many other things besides the stent, and that also depends on the degree of the disease that is there, the response to chemotherapy, the response to whatever infection the patient has, how sick or what is the performance status of the patient prior to his stenting. So all those things matter, and I think that is where everybody has to get together to decide as to what is the best type of stent to be put. So basically, I would think that this data has shown us that stenting is very much feasible. You can put most of these stents, especially in malignancies, under conscious sedation. It gives good immediate relief. Stent-related complications are not much, but we need to learn from each other much more as to how to and where to, not the how to is being more or less solved, but where to and when to is a question which needs to be addressed further. Yeah.
So I think, thank you, sir. I think we had some more concerns, tumor overgrowth, the stent. I think let's have a rapid fire with Jinam. Jinam, tumor overgrowth over the stent, you take it out?
I may remind you, Ullas, that Dr. Karan, who's here, has also got a very large experience of stents, and maybe you could also,
let me choose.
Can I ask a question, please?
Yes, Dr. George.
Yeah, but I loved Dr. Goel's presentation and the data which he's presented. And we almost came to the same conclusion. We have a very limited data set, so we're not very liberal with using stents. But the numbers are similar, that 22% of our patients did not survive more than a month. But in the ones who survived, the quality of life improvement is significant. So it's a very important consideration to pick the right patient. And we've not done it very well from our side. There's room for improvement, particularly when economics is a huge aspect. Now, in a general hospital like ours, when we have to mobilize the money for the stent, where we could utilize the money for something else or some other patient or some other form of treatment, it becomes critical. So Dr. Goel's patient point about picking the right patient for stenting is very important.
Fantastic. So, sir, since we are very, very late, it's going to be rapid fire. So any of the pulmonologists can take it, but Dr. Karan Madan, Dr. Rajiv Goel has said, so I'll ask him. Dr. Karan, can you hear us? I think he's not there. So Jinam?
Yeah.
Hello.
Okay, I think he has come. Okay, Jinam, the first one goes to you.
Some network connectivity issues, I am back.
No worries, no worries. So Jinam, tumor overgrowth over the stent, you take it out, or what do? You put a stent over stent, or what do you do?
So
Dr. Karan has come.
Generally in lung, we don't prefer to put in stent over the stent. What we'll do is just do a bronchoscopy, possibly just remove whatever tumor has come in. Worst come worst basis, if the tumor is too much, it is not able to remove bronchoscopically, we remove the previous stent and we put in a new stent over it. That would be the ideal way to go about it.
Dr. Karan, average lifespan of the patient, of the stent, not the patient?
Yeah, so I think there is the silicone stents are pretty sturdy. If you put them, then the life of a stent is never an issue. Okay. With a metal stent, there is a quality issue. We've had an issue. There are inter-manufacturer differences in which some stents, fracture quite easily. Regarding tumor overgrowth, it would be variable. Sometimes in CA esophagus, with an extensive growth, you might want to, place a longer stent or a coaxial stenting, maybe sometimes, required in certain patients, because removal of obstruction sometimes may be, kind of risky with a lot of extrinsic component. So I think metal stents are usually shorter lived than a silicone stent, but mostly in malignancy, it's the metal stents which are preferred.
Can it get dislodged? I mean, this is Bollywood imagination going on Thursday evening. Stent coming from there, going somewhere over there.
Yes, so I think this is not a very rare phenomenon. If you undersize a stent, the stent can migrate distally or proximally. It is more likely if you have smooth extrinsic compression and not a tumorous infiltration. We've had also a situation in which a silicone stent, patient coughed up and it got stuck at the cords and, there was aphonia. So I think dislodgement issues are rare if you size the stent properly. As was told by Dr. Pattabhi, if you can put a stent easily, a silicone stent, it is usually an undersized stent. So I think sizing issues are very important.
So last one, can the stent be safely removed? Yes, everybody has said. How many stents have we removed, let's say in your practice?
So silicone stents, especially for benign indications, are
malignancy.
So in malignancy, a removal rate in our experience is quite less, because the complete response rate or a response in which patients, get disease free is quite uncommon in our experience. So I think most of our patients have stayed with a stent once they are put in. I mean, that's my general feeling.
Okay.
Yeah, Ullas, can I just add one more to that? I think Sachin mentioned adenoid cystic carcinoma. So I think those are the patients who do well. We've had experience of removing a stent after 9 months, a Y stent successfully. And similarly, there's another patient waiting now who's 6 months gone after radiation with adenoid cystic, and whose stent we intend to remove. So those are the patients who do well. And can actually sort of can benefit from the
I think, sir, I did ask a very a question in the beginning that biology trumps anatomy. I think the biology does trump anatomy. And adenoid cystic carcinoma, ALK positive, these are the people you will actually get
but you must understand that guy is living because the stent was there for those 9 months.
Absolutely right, sir. Absolutely right. We are not saying that. That's why I'm telling you, biology trumps anatomy.
Anatomy has been taken care of. That is why the biology has been allowed to work.
I knew you will answer, sir. So that's why wise you are in the ways of stent. I put this across over there, sir. So this is my last slide. It's been a fantastic thing. I think teamwork is the key. Whatever we may say, we may make jokes, but teamwork is the key. We need to, because patient is at the center of this. And thank you for the learning. Thank you for the great learning. It was a fantastic session, and looking forward to the future more. Thank you. I hand it back to the organizers. And can I please request Dr. Kumar to say a word or two at the end of it? Kumar?
I think he's not there.
No, he's there, but I think he's muted. Okay, fine. Doesn't make a difference. So it's been Kumar's, I would say it's been Kumar's baby. Kumar was the one who instrumental in.
Go right across and call him. He lives next door.
So Dr. George, you can do the honors on that.
No,
So I think Dr. Rajiv Goyal or somebody can give the closing remarks, and then we can.
So I think perfect evening, and
thank you, Ullas.
It has been stretched a
wonderful
bit,
panel.
Kumar has here, sir.
I must say that
Dr. Rajiv needs to do. I'll just thanking you.
Yeah, so
and others.
Yeah, thank you, Kumar. So it's my privilege to kind of round it off, and basically I would say that it's a privilege also to see that some of the pioneers in stenting were here today. We had Pattabhi, we had we had Ravi, and we had Karan. So these guys are the ones who are actually holding it aloft, and then we have youngsters like Jeenam, and Sachin, who are taking the science forward. So I think that the future is in good hands, and I'm sure that the message which comes across perhaps is that we need to choose wisely. We need to be wiser in terms of and that is why I think this data and trying to document whatever we are doing and seeing how these patients fare subsequently. That is what actually tells us how actually successful we have been. So if a patient benefits and benefits for a long time, that is where the success of the stenting lies. And I think that message has come out very nicely. And I thank everyone for being here today. And I thank the organizers again. Kumar, you and Ullas, you brought this wonderful sort of meeting together. And thank you very much, and look forward to meeting you all again. A very good night to all of you. Thank you so much.
Bye-bye. Thank you so much.
Good night.
Thank you, everyone.
Thank you.